Okay, so today with me is Dr. Pranay Vajpayee. You must have recently seen that he has joined the faculty network of ESBICM, and he wants to share a case and want to highlight the clinical importance of clinical examination and thought process, which we all should do, those who are working specifically in intensive care. So now we have Dr. Pranay Vajpayee. Thank you, sir. Please share the case with our.
So, good afternoon, friends. Today I am sharing an interesting case. So, it's a 38 years female, known case of ITP on steroids, maintaining platelet around 1.3, 1.4. She was referred to our department of respiratory medicine and critical care from a gynec. She was posted for a surgery for uterine fibroid due to unexplained dyspnea, although she was not having any anemia. So when she presented, she gave classical history of exertional dyspnea. So whenever there is a history of exertional dyspnea, the first investigation we do is an ECG. The second investigation we do is an X-ray. She had multiple ECGs and multiple X-rays, and all were reported normal. So on examination, her chest examination was broadly normal, but her saturation, resting saturation was around 95. And when we make her walk, do a 6-minute walk test, her saturation dropped to almost 90%. But another thing, she was not having any clinical signs of cyanosis, clubbing. So we had a thought that why she was having this kind of presentation. We have planned further investigation and X-ray again, and followed by echo and then a CT chest with contrast. In this case scenario, as a patient, we are seeing, we should always listen to the patient, because the patient never lies. And when you have a careful history of your patient, you can rule out certain diseases. In these cases, why we have done this investigation? Because first, a normal X-ray, a normal ECG, a normal clinical findings, but hypoxia. So the first thing to rule out is pulmonary embolism, but the patient history was long-standing. She has visited multiple clinics for past 6 months. The second can be primary pulmonary hypertension. For that, we have done all the investigation, and I think other team has seen shares the investigation on it.
Sir, if can we think of myasthenia in this patient?
Yes, we have taken another important point of myasthenia. We also thought that why not this is myasthenia, but there was no diurnal variation, there was no there was no diplopia, there was no evening change of voice, there was no change of respiratory pattern in the evening. So no diurnal variation.
So the only thing was dyspnea, which was exertional, and there was no signs of pump failure. It could be like myasthenia or that. So another interesting thing which we find on the echo was the LV was normal, left ventricle functions were normal, but RA-RV were dilated and the pressures were 60. So again, it narrows down to diagnosis. So something in the right heart failure, and the commonest which we see in the emergency in ICU is pulmonary embolism or primary pulmonary hypotension. So the further workup went to the radiology team, and we will see their narration in the coming minutes. But the point which Dr. Pranay wants to say that always think why this is happening. Don't ignore the patient's signs and history. It is very, very important. And to mind you, this patient was having multiple consultations outside for the same. So let's see what comes out in the imaging. To tell you that grossly her X-rays were normal as per the patient where she has shown. And now with me is Dr. Nitika Benjamin, who is the HOD of the radiology department, and with me is Dr. Sujay also, who will take care of the CT. And now first, madam, let's see what we find in the X-ray.
So, good morning. This lady who presented in the emergency with the shortness of breath. Her chest x-ray was done in the department, and sometimes we are lucky to see certain very uncommon abnormalities in our lifetime. So this is also one of them. So the chest x-ray of this, the lung fields are basically clear, but then we see a radio opaque, radio dense shadow, tubular shadow, which is paralleling the right heart border. So it is a homogeneous shadow starting from the hilum and reaching till the diaphragmatic surface of the patient. And you can say that why is this not a normal pulmonary artery? So when we see the x-ray in detail, we see that the connection of this tubular shadow to the hila is missing. We cannot see that connection to the hila. Secondly, the pulmonary artery shadow is also parallel to the right heart border, but then it shows gradual tapering as it descends down. But this is a homogeneous tubular shadow which is seeing going inferiorly till the diaphragmatic surface. So we'll just have a look at the x-ray of this patient. Yes. So here is the lung fields, as you can see, are relatively clear. Then we see this tubular shadow, which is starting from the right hila and coursing inferiorly, and then the shadow is merging. But then we can see this traveling the diaphragm and going infradiaphragmatically. This tubular shadow. This is not pulmonary artery. This is a sieve of pulmonary artery which we can see behind this shadow. So this is a anomalous pulmonary venous drainage of this patient fitting into the Scimitar syndrome. Scimitar, which resembles the Turkish sword. So this is a Scimitar syndrome. Though many of the cases of Scimitar syndrome are associated with lung hypoplasia, but in our patient, hypoplasia is not there. The lung volumes are normal. We did a CT scan of this patient to confirm our findings. And let's see what the CT has to say about it.
Madam, can you show the sword sign which is based on that?
Yes, yes. We have a net picture of that. Yeah. So as you can see, this is the tubular shadow. This tubular shadow, but this X-ray, this has a homogeneous opacity along the right paracardiac border of the lung, which is obscured by this shadow. So this patient probably has a pulmonary hypoplasia of the lower lobe of right lung, and this is that picture of the sword, mimicking this opacity is mimicking this shape. So from where it derives its name of Scimitar syndrome.
Can we get back to our X-ray also to see this sign?
Yeah.
So I think
this is the same way. This is the shadow, and it is taking the shape of that sword which we have seen in the book picture.
Thank you, madam. And now I request Sujay to please show us the CT scan findings.
Hello, so we have a CT scan of the same patient. I've directly gone to the post-contrast, post-processing images of the same patient. So here you can see, I'll just give you a quick run through here. So this structure is the pulmonary artery here on the right side, and it's normal. Adjacent to the pulmonary artery are the pulmonary veins. This thing is the pulmonary vein.
So where was the artery? This was the pulmonary arteries, right and left.
Yes.
Okay.
This is the right artery and this is the left one. You can see it's dilated. You always have to compare it with the adjacent aorta. You can see it's fairly larger than the aorta, so it means it's dilated, which is a direct sign of pulmonary hypertension.
On echo also they found pulmonary artery hypertension. Yeah. So they were of the initial impression that we should rule out pulmonary embolism.
Oh. But this structure here, this thing, now these are the pulmonary veins right adjacent to the pulmonary artery. This pulmonary vein, if we go down and trace it, it should come towards the hilum where it forms the main pulmonary vein and drain into the right atrium. But in this particular case,
Left atrium.
sorry, left atrium. But here in this case, you can see it better on the coronal images. This pulmonary vein instead is going directly
This one. This is
Yes.
going into the
suprahepatic IVC.
rather than going into the heart, it is
Going in.
collecting and going into the.
Into the suprahepatic IVC.
This again, blood is going to the right atrium and right ventricle.
Right.
So it's sort of.
So it's a form of partial anomalous pulmonary venous return.
So it's become a shunt.
It's a shunt.
So the oxygenated blood is going back into the deoxygenated circulation.
Sorry.
What about the left pulmonary veins in this?
So left pulmonary veins are normal. And yeah, they are draining normally.
Show the stump of the
And if you'll see the right pulmonary vein here, you can see it's atretic, like only a small stump is seen. So there is a hypoplasia of the right pulmonary vein. Instead, they are directly, the veins from the upper and the lower part of the right lung is draining directly into the suprahepatic IVC.
Okay. So thank you, Sujay. So the point which we are trying to say in this session is she is Dr. Namrata, who is working on a different project. So the point which we are trying to say is whenever you feel that the patient is dyspneic, specifically if it is not a clear cut of lung findings on clinical examination, the heart is also okay. Don't just look at the left side of the heart. If something is wrong with the right side of the heart, obviously pulmonary artery pressures were increased, and so always you need to find out the cause. Most common cause is your pulmonary embolism in that. Also make a habit of reading the x-rays carefully. If something abnormal is there, try to figure it out. In this case, what happened, there was a rare case, we find a shunt, the pulmonary veins, not technically pulmonary veins typically, but it is a sort of venous drainage which was draining into the IVC and it was creating shunt. So we found this, and what now they will do is, there are two approaches to it. Either they will create a sort of pathway from foramen oval between the two atriums, so that from right atrium the blood goes to the left atrium, or they can do a surgery in which the pulmonary drainage from the venous, which is draining to the IVC, sort of will put it into the left atrium. So always try to find out the cause, why this is happening. Look at the x-rays imaging carefully. Always try to find out the reason why this is abnormal, and this was, we are lucky to share that something not very common, we were able to figure it out. So thank you, Dr. Nitika, thank you, Sujay, and thank you, Namrata. She is also very much part of the radiology team and very interested in the academics. You must have seen her on the previous videos also. Thank you, and we'll come back if we had some other interesting finding. Thank you.
Thank you.